when I first saw this a few years ago, and then had the opportunity to look at the paper in the Journal of Urology in September, and then interview Steve. This is amazing. I mean, it really is. That you're right. I mean, we're seeing this sort of significant response with minimally invasive procedure in BPH like we've never seen before. And then you think about durability, and you showed us the retreatment rate is pretty low at 1 year. I guess the first thing that comes to my mind is, well, we've been doing something, TUIPs for years. Yeah, we don't compress the tissue, but we've used balloons in the past and things like that. And then I think of, all the other questions people are going to ask about how big of prostates can you treat, size, and so forth. You said there's no change in sexual function, that really no retrograde ejaculation, things like that. So let's start. Who wants to talk about something similar to TUIP and what effect the paclitaxel and the dilatation has? Dean?
I'll make a quick comment, and then let Dean talk a little bit about the paclitaxel and the role. So it's kind of an upside down TUIP, as the case may be.
Yeah.
But clearly, I think it seems, and interestingly enough, when we used to do suprapubic or retropubic prostatectomies, we always started by cracking the anterior commissure. That's where we started. So clearly, when we crack the anterior commissure, it changes somehow the fluid dynamics within the prostatic urethra. That's just clear. We've seen that because we don't remove tissue. So changing that structure results in flow rates just as good as if we did remove a lot of tissue. So unlike the earlier balloons in the 1990s, where all it did was kind of dilate and then snap back, this doesn't snap back. And I think that's maybe the difference why we've had some good durability.
Yeah, it's really like opening the floodgates. Like you're really opening up the prostate and separating it. And it's that change in probably the resistance at the bladder outlet that is the big difference. But of course, the key feature here is the paclitaxel, right? As opposed to a TUIP, which works, but may not have the same durability. Why? Because when you cut into a prostate, your body wants to heal. There is going to be an inflammatory response and healing of that incision, whereas the paclitaxel is really designed to keep that opening open. And that's why we see, I think, the durability that we're seeing. It's a big difference between just making an incision and having the medication keep it open.
Interesting. So paclitaxel, you always think about that as chemotherapy. How what's the hypothesis on how that works? What difference does it make?
Well, it probably reduces an inflammatory reaction, reduces the inflammatory reaction, I should say, so there's less scarring. So I think it just, and the exposure is obviously not nearly as much. And we had to do semen analyses and and testing as part of the FDA regulatory cycle, and there was no effect. Although we tell patients that if they're going to have intercourse and ejaculate, they should wear a condom for the first 30 days. And just be a little careful of that. And that's just a safety issue. But we didn't find anything of substance affecting it. But it's hypothesis. I think there are folks who are going to really look into what it actually does. And I'm sure there may be some type of factors that are being expressed or being inhibited by the paclitaxel. I'll be curious to see what it does. But this is also the first dual therapy we've ever seen as a minimally invasive device. It's a device and a medication. So we've never seen that before either. And I think that's what makes it exciting. And frankly, that contributed to its great reimbursement, because I think it's the first dual therapy, as the case may be.
So in the preclinical trials, your phase 2 study, were there any studies done with just the catheter and the dilatation and the anterior commissure fracture, and not with paclitaxel?
No. And again, just historically, this didn't come out of thin air. The inventor was someone who was involved in the cardiovascular space, and he was using paclitaxel in the coronary arteries and various types of other blood vessels, and just applied it because he's from China and had noticed there was a huge study of almost 6,000 balloon therapies done in some centers in China with good results. And he thought, okay, why don't we design one for the prostate? And that's how it came. And obviously, there's also a device for urethral strictures that has been doing quite well as well. So that concept seems to be good.
So the urethral stricture, right, work?
Mhm.
Yeah, and I thought that was interesting too. So this is I just look back and this is absolutely amazing. All the different therapies we've used for BPH in the last 3 decades, Steve. The things we've looked at. It's simple. I guess that you can do it as an outpatient, but you can also do it. I mean, without anesthesia, with and without. I would guess that in the trial, was anesthesia used routinely, or it was sort of the investigator choice, or what?
Most of these patients were done in the center, so they got some type of anesthesia, usually some sedation, and not dissimilar to what we saw with some of the other clinical trials. And Dean will talk a little bit more about the anesthesia that he uses with his tips and tricks, as the case may be. So we've done ours in the office, and we give them a combination of some local anesthesia and some sedation. I believe we did microwave and transurethral needle ablation in the office with prostate blocks, and microwave is a longer procedure and much more painful. So it's pretty well done. As long as you're confident with doing a prostate block at minimum, it shouldn't be a problem.
So I mean, basically say there's no no significant change in sexual function, and so no ED that you've seen between that and the sham, and retrograde ejaculation, right?
That's right. I mean, we're really making this anterior commissurotomy along the whole length of the anterior aspect of the prostate, and it's nowhere close to the inferior apical tissue, nowhere close to the verumontanum or the ejaculatory ducts. And so we have not seen any changes in IIF or ejaculatory function on MSHQ. And in my own clinical practice, I've been doing this now commercially in my practice now for a while. It was in Canada before the United States. We also have not been seeing any changes in sexual function, be it erections or ejaculation. So it really is a sexual function preserving minimally invasive treatment.
So I guess another question that comes to mind is, what about someone's on blood thinners or aspirin or things like that? Any bleeding complications, or what are your restrictions on utilization there?
Yeah, I mean, as is the case for all the minimally invasive treatments, my recommendation is to hold blood thinners. We're doing a quality of life procedure in an outpatient office setting, so we always want to minimize and mitigate risk. Certainly with the Optilume, there's no cautery, there's no hemostatic maneuvers, and so you really are opening up the tissue. So I have my patients hold their blood thinners. And at the end of the case, as you'll see in our next video series for tips and tricks, we typically put in a 20 or 22 French catheter. We do some gentle manual irrigation, and they're able to go home. So I'm performing this as an outpatient out of my office with no need for admission or bladder irrigation.
Do you send the patients home with the catheter?
Yeah, so we do send the patients home. I've been following the guidance from the clinical trials, which is I leave the catheter in for 48 hours and I have them come back to get the catheter taken out.
So any other comments from you, Steve, before we end this?
No, pretty encouraged by the data. I remember when Dave Perry, who was the CEO of the company Eurotronic that helped bring this forward before it was bought by Labary, when he first asked me about it, I said, "Are you nuts? What type of crazy therapy do you want us to do?" And then when I spoke with the team and the science team and the inventor, it began to make a little bit more sense about what we can do theoretically. And then to watch it in practice, it was like growing a baby into a fully mature adult, just watching this happen. And it's one thing for me to believe it, but when other people experience it of different ages, like, Dean experiencing and sharing that type of data, and we've had that data now along many investigators, and multiple people have noticed this. It's kind of cool to see that we're really making an impact, and ultimately real world data is going to determine how this is going to play out. But if it's anywhere near the registration date, this is going to be a major game changer.
Well, I went, when the paper came out and I saw it and I heard a little bit about it before, quite honestly, I was skeptical. But I did see your names associated with it and I said, there's some science here, something that's going on, and that's the reason that we had our first interview, which was great. And at that time, it wasn't readily available. It was just being introduced. What do you want to, maybe before we end, comment on availability around the US, Canada, things like that?
Well, it's now in the hands of Laborie, and they certainly are making it available in the United States. It's now FDA approved. That as you saw from Steve's portion, there is reimbursement. And so I think more and more people are really, especially after the most recent AUA, where people were able to see it, to put their hands on it. It's certainly, the adoption is picking up. So my understanding is readily available and approved in North America, nowhere else, I would add. It's not yet available in the rest of the world, but it is certainly gaining traction in the United States.
And I know there's been a lot of attention to this and interest, and I think Laborie's really done a good job of taking the steps slowly and making sure they're putting it in the right places and people are trained. And the reason I know this is because in San Diego, we're going through this right now, and I think that's the way to do it. So I want to thank you both for your time, and then we have a couple more of these episodes of this trilogy coming up to follow this. Thank you.